Sorry for the hitch. Good afternoon, everybody. Greetings from NITRD and a heartfelt welcome to all our esteemed guests and colleagues to the 6th NITRD Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The aim of these clinics is to disseminate the pediatric TB guidelines and build the capacity of our healthcare providers to diagnose and manage pediatric TB cases, even at the peripheral level. On behalf of NITRD, I extend a warm greetings to our DDZ ma'am, Dr. Urvashi B. Singh, and her team, along with the directors and teams from NIIT, NTI, STOs, directors of STDCs, faculty of medical colleges, TB pediatricians, and everyone who is attending today's clinic. Let me introduce the faculty from NITRD. I am Dr. Saroj Meena, chess specialist at NITRD, and I'll be moderating today's session. To my right is Dr. Sangeeta Sharma ma'am. She is a former director of NITRD and consultant in the Department of Pediatrics at NITRD. And to my extreme right is Dr. Alok Yadav sir. He is CMO NFSC in the Department of Pediatrics at NITRD. To my left is Dr. Dhulika. She is specialist pediatric in the Department of Pediatrics with NITRD. Now I request our director ma'am, Dr. Manpreet Bhalla ma'am, to give her inaugural address for the clinic. Over to you, ma'am.
Thank you, Dr. Saroj. Good afternoon, everyone. And once again, I welcome you all for this pediatric TB Eco Clinic. And as you know, we hold this clinic. We know that pediatrics diagnosis of pediatric TB is very challenging, and for getting the specimens, for doing the diagnostic tests, especially for extrapulmonary TB. So we are addressing in these sessions, we want to address all these difficult things. And today's session is for challenges in managing TB with subtherapeutic drug levels. So this is another new challenge which we are facing. And this is meant we hold these clinics in order to support, as you all know, Dr. Sangeeta Sharma and other experts are there who will guide the other centers for taking decisions and managing these difficult cases. So over to you, and welcome everyone once again. Thank you.
Thank you, ma'am. Now I request our DDZ ma'am, Dr. Urvashi B. Singh, to give her inaugural address to the clinic.
Good afternoon, everybody, and thanks to NITRD for continuing to host the difficult to treat clinic, whether it is pediatric or adult, EP, MDR, TB, and they are always there to train all the medical experts who are dealing with patients in the periphery. So thanks to NITRD, thanks to the team, and most of all, Dr. Sangeeta, who's been doing such wonderful work with children, whether it is DRTB, whether it is extrapulmonary TB. She has, spent all her, good years, productive years in the service of children. And thank you, madam, for that and your commitment to the children. I have seen how the DRTB children who have been cured have, so in one of the previous meetings, those children were there, and the joy that one gets out of seeing those children healthy and interactive after having been treated by Dr. Sangeeta's team for difficult, DRTB. It was very, encouraging, and that actually shows how much energy and how much passion she puts into the children that she treats. So thank you for bringing us this difficult to treat spinal TB child. Now, briefly to talk about the therapeutic drug monitoring, which Dr. Sangeeta will allude to at length today. We have had few sessions where we have talked about lower blood levels found in children or in adults who were not responding to their treatment, and Of course, this brings us to the facts that could be responsible for lower levels, which could be drug quality, which again has been tested many a times with best of pharmacologists. Dr. Bikash Medhi at PGI Chandigarh has done that. But in fact, all our batches before they are sent out are tested for the drug quality. So if drug quality is not an issue, then where is the issue? One such issue was highlighted in one previous meeting where Dr. Singla was presenting a case, where again, what needs to be understood by all of us is there may be intestinal factors for which may not allow good absorption. There may be factors such as poor BMI and poor intake of food, which may be affecting drug absorption and hence the poor drug levels. So the fact that I think at the end of the clinic, Dr. Sangeeta will also summarize that we have to be aware of issues that could lead to poor response or poor regimen response, and where we would like to possibly alter the regimen, which can be one call. But if we know the drug levels by altering the dosage, we could possibly help the patients. Of course, we're not going to give a dose which is not under the accepted range, but those are the things I think she'll be able to shed more light on depending on the case. The other challenge is, of course, the reach of the drug in extrapulmonary sites where fibrosis and poor blood supply could compromise drug levels actually reaching the site of pathology. So again, that is another question for all of us to deal with and find an answer to. But with this, I think I'll close the introductory comments and let the discussion go on. And thank you to all the interested medical officers who have spared the time from their busy schedules to join here. This just shows how committed they are to learn more, to be able to give more to their patients. Thank you all.
Thank you so much, ma'am, for your motivating words and your unwavering dedication to these clinics, which inspires us to continuously improve and strive to achieve our goals. There's a small announcement. There's a pre-test link has been shared with you in your registered email ID and also in the chat box. Kindly complete it at your earliest convenience. Now moving on to today's case presentation. Today's case is from the Department of Pediatrics at Grant Government Medical College and Sir JJ Group of Hospitals, Mumbai. Dr. Sumanjali Reddy, third year resident at Grant Medical College, will be presenting the case. And our case expert for today is Dr. Sushant Satish Maine. He is an associate professor and nodal officer for pediatrics, State Center of Excellence for Tuberculosis at Grant Medical College and JJ Group of Hospitals, Mumbai. Our national expert for the day will be Dr. Sangeeta Sharma ma'am, former director of NITRD and consultant pediatrics and in charge of the National Center of Excellence for Pediatric TB and DRTB at NITRD. Now I request Dr. Sumanjali Reddy to please start with the case presentation. Over to you, Dr. Suman.
Yes, ma'am.
Good afternoon, everybody. This is Dr. Sushant. Apologies because we are not able to start the video. There is some internet connectivity issue. Otherwise, the voice is fluctuating. So we are not putting on the video. We are just sharing the presentation. Dr. Sumanjali will start the presentation. Are we able to see the PPT?
Yes, Dr. Sushant.
Yes. Okay.
Good afternoon, everyone. Today I'm discussing about the difficult to treat TB case presentation. A 14-year-old girl, second birth by order, born out of non-consanguineous marriage, resident of Navi Mumbai, Muslim by religion, mother being a reliable informant, was brought to our casualty on May 2024 with complaints of fever on and off since 8 months, left ear pain and discharge since 8 months, headache on and off since 8 months. As the patient has significant previous clinical course, we would like to describe the same. Patient's complaints first started in October 2023, where patient had developed fever spikes which are low to moderate and left ear discharge and pain with intermittent headache since 2 months. Patient consulted various pediatricians for the same complaints and was given symptomatic treatment for these 2 months along with oral antibiotics for ear issues. Due to non-resolution of symptoms, she was then taken to a private medical college where she was admitted for 1.5 months from 20th of January 2024 to 1st of March 2024 and was investigated as follows. CBC showed mild anemia with leukocytosis with neutrophil predominance. Liver function test, renal function test, and serum electrolytes were in normal range. HRCT temporal bone was done in view of ear discharge, which showed left-sided acute otomastoiditis, query malignant otitis externa with skull-based osteomyelitis. And then MRI brain was done to look for the extension, which showed meningeal thickening and enhancement noted involving the left medial cranial fossa, suggestive of meningitis, and extension noted in left middle cranial fossa, which is seen abutting and displacing the left inferior temporal lobe with no altered enhancement is noted involving left temporal lobe, which is a possibility of vasogenic edema or early cerebritis. And also it also showed left-sided acute otomastoiditis. Because MRI brain showed meningitis, the CSF analysis was done and the CSF sugar was 15, CSF proteins were 214 and WBC counts were 18, in which neutrophils is 10% and lymphocytes were 90% and RBCs were absent, and the culture sensitivity showed no organism isolated, but the CBNAT was not sent at that point. And then CT brain venogram was done to look for the sigmoid sinus thrombosis, which showed focal indentation on left sigmoid sinus without thrombosis. And the chest X-ray showed right upper lobe partial opacification with volume loss, query collapse. And then CCT thorax was done, which showed posterior aspect of left fourth rib osteomyelitis with pathological fracture with no significant underlying lung parenchyma involvement. And also few fibronodular changes are noted involving posterior segment of right upper lobe. But the patient had lost the X-ray and CT films when she came to us. And the patient also had contact history of pulmonary DSTB in father in the past 2 years. Based on the history of insidious onset meningitis with lung lesions and also history of significant contact, the girl was clinico-radiologically diagnosed as tuberculosis and was started on DSTB regimen on 10th February 2024 with fixed dose regimen, which is 3 pediatric dose and 1 adult plus 3 ethambutol. Weight of the patient then was 29 kilos. And also during the course in the hospital stay, ear pus culture grew Pseudomonas aeruginosa and was treated as per DST report. Then the girl was discharged after explaining the anti-tubercular drugs and follow-up schedule. After about 1 month, she developed acute pain in abdomen, vomiting for 2 to 3 days and was taken to another private hospital nearby where she was admitted for 15 days from 1st of April to 15th of April 2024. And then CBC showed moderate anemia with leukocytosis and liver function tests were normal. Renal function tests and serum electrolytes were in normal range. And then CCT abdomen was done. CCT abdomen showed subacute intestinal obstruction secondary to infective etiology, mild reactive thickening of appendix wall, few subcentimeter size partially necrotic lymph nodes and pre and para-aortic area. And the patient received injection meropenem, amikacin, linezolid for 10 days in the same hospital and Dexa for 3 days. And the symptomatic treatment was given for fever and abdominal pain. And the first line AKT was continued. And then the child was discharged after symptoms improved. After 3 weeks of discharge, patient again started having fever spikes, throbbing headache, which is poorly responsive to medications. And for these complaints, she was brought to us at JJ Hospital in first week of May 2024. On admission, history suggested of weight loss from 29 kilos to 24 kilos in last 3 months. And GCS was 11 by 15 and she was drowsy. And she was febrile with 101 Fahrenheit fever. Pulse rate was 88 per minute and respiration is regular. No evidence of papilledema. No obvious neurological deficit or cranial nerve palsies. And the chest X-ray which was done suggestive of bilateral hilar lymphadenopathy with right lower zone infiltrates. And the CBC showed moderate anemia with leukocytosis with normal platelet count and liver function test, renal function test and serum electrolytes were in normal range. MRI brain was done in view of the persistent headache, and it showed left-sided otomastoiditis, left subdural empyema, sigmoid sinus thrombosis, multiple conglomerated peripherally enhancing lesions in right basifrontal and suprasellar region and left temporal region, which was suggestive of tuberculosis, and left basal temporal lobe abscess, which is 1.1 into 1.3 centimeters, and right frontal lobe abscess, which is 1.1 into 1.5 into 1 centimeter, and leptomeningitis, third and fourth ventriculitis, and communicating hydrocephalus with Evans index 0.32. The ones which were highlighted in red was not noted in the previous MRI brain, which was done 3 months ago. And CSF analysis was done. CSF sugar is 18. CSF protein was 84. In routine microscopy, it was clear, and leukocyte count was 150 with neutrophil count 90% and lymphocyte 10%. RBCs are 0 to 1 per hyperwork field. And culture sensitivity grew no organism. And CBNAT was sent, and which showed MTB was not detected. And sputum CBNAT was done, which was MTB detected low with rifampicin resistance not detected. And ear pulse CBNAT was also done, which showed MTB not detected. And MGIT cultures at 6 weeks were negative. And as both temporal and frontal lobe abscess were not accessible for surgical drainage, right terional craniotomy with biopsy of suprasellar tuberculoma done to rule out drug-resistant TB. And then that brain tissue biopsy CBNAT showed MTB detected low, rifampicin resistance not detected. And MGIT cultures at 6 weeks were negative. Compliance and adherence to anti-TB drugs was assured from the patient and parents. And this impression is a 14-year-old girl with disseminated drug-sensitive tuberculosis, which involves pulmonary plus neuro plus abdominal with failure to respond to therapy. Taking into account the clinical course and the following, which were with the persistence of symptoms, significant weight loss from 29 kilos to 24 kilos, appearance of new lesions in the brain, and we ruled out DRTB from by doing CBNAT from two sides from sputum and brain tissue after 60 days of anti-tubercular therapy, suggesting MTB detected low and rifampicin resistance not detected. And also ruled out intestinal malabsorption. Clinically, there were no symptoms of malabsorption, and also stool assay was normal, confirming good compliance to the therapy. Considering all these, low therapeutic drug levels were suspected and drug levels were sent. Therapeutic drug levels, which were done on 12th of May, showed serum rifampicin and isoniazid levels were below the reference range at 2 hours. And at that point, child was on intensive phase of DSTB on 3P plus 1A plus 3E, and the isoniazid which was given at 10 mkd was dose increased to 15 mkd, and rifampicin which was going at 15 mkd, the dose increased to 25 mkd, and the pyrazinamide and ethambutol were continued at same doses, and the fixed dose regimen was changed to individual drugs, and the dose increased as per the DST report. Normal values of rifampicin was 8 to 24, and the patient showed less than 0.2, and isoniazid the normal range was 3 to 6, and the low level and the patient showed less than 0.5 at 2 hours. And the repeat TDM levels were done again after 14 days after increasing dose of rifampicin and isoniazid, and which both were in normal range. And the rifampicin now the current levels were 9.4 and isoniazid were 5.9 mg per liters. Course in the ward. On admission, anti-rape ICT measures were given on admission. The DSTB regimen restarted and steroids added in view of CNS TB. Individual DSTB drugs given instead of fixed dose regimen. ENT reference were done for ER discharge, ER toileting done, and appropriate antibiotics.
Dr. Sumanjali, you're not audible.
Sorry, ma'am.
It's come close to the system.
Ma'am, am I audible now, ma'am?
Yes, please carry on.
Sorry for the disturbance, ma'am. Course in the ward was on admission, anti-raised intracranial pressure measures were given on admission. DSTB regimen restarted and steroids added in view of CNS TB. individual DSTB drugs and the dose increased as per DST report. And ENT reference was done for the ear discharge. Ear toileting was done and appropriate antibiotics were given as per pus culture sensitivity report and was advised a regular follow-up. After increasing the dose of antitubercular drugs as per the therapeutic drug levels, symptoms gradually relieved over 2 weeks and adequate weight gain was seen. Patient was then discharged on 6th of June 2024 and was advised regular follow-up. Patient came for follow-up once in 4 weeks after discharge, and the status on 28th September is she was on continuation phase of DSTB therapy and was compliant to the therapy. And steroids were omitted after tapering the doses, and no active symptoms was there, and adequate weight gain was also present, and the present weight was 30 kilos. And the final impression was disseminated drug-sensitive tuberculosis involving pulmonary and CNS plus abdominal with failure to respond secondary to low therapeutic drug levels of rifampicin and isoniazid. A few points regarding therapeutic drug monitoring in patients with tuberculosis. Suboptimal drug exposures may be associated with acquired resistance and poor treatment outcomes, whereas supratherapeutic concentrations may lead to toxicity. So, therapeutic drug level monitoring is not a part of routine practice, which reflects both the efficacy of the regimen and also the high cost and complexity of the test. Factors associated with low therapeutic levels are poor compliance and adherence to medications, repeated vomiting due to adverse effects, poor gastrointestinal absorption, low albumin levels, presence of comorbid illnesses like liver and kidney illnesses, and HIV infected patients, extensive involvement of tuberculosis, drug to drug interactions. Low therapeutic drug levels are often seen with isoniazid and rifampicin. Patients with low drug levels take longer time to culture conversion from positive to negative. However, final treatment outcomes are not affected because doses were adjusted and therapy was not often prolonged. These are the references I took from. Thank you, everyone.
Thank you so much. It was an excellent case presentation. Just to summarize the case for all those who joined a little late for us, was a case in discussion was a 14-year-old girl, diagnosed case of disseminated pox, PTB, CNS TB, and abdomen cough, who initially was diagnosed on the basis of clinical radiological features and was started on DSTB treatment. But after 3 months, in between, patient faced many complications of pain, abdomen, and all, so that she needed to admitted in a hospital. And after 3 months, when she presented to the current team, the patient, they did the repeated scanning and imaging, and which shows an increase in the lesions along with the increased symptoms and loss of weight. So after further workup of the patient was continued to be drug sensitive TB, doing CBNet through CBNet, and cultures were negative. And patient was also dealing with dual pathology of ear discharge, and which was of pyogenic cause, for which the symptomatic treatment was given to the patient. They did the therapeutic levels which found to be suboptimal level, and accordingly the team increased the levels to the doses of the drugs, and thereafter the patient improved and symptoms resolved, and finally they increased the therapeutic levels of the drugs. The house is open for the questions. Even audience can ask any questions from the team. You can write down your questions in the chat box also if any queries. So it seems it was very clear. So moving ahead with the today's case presentation, I would like to call Dr. Sushant Mane to provide his insights and recommendation in managing such cases. Over to you, Dr. Sushant.
Everybody. So the first thing what we came across in this was, in the first time in January when she went to a medical college, she had all the background of fitting into a presumptive case of TB. But still, CBNet was not sent at that particular point of time. So that is one thing that still we get such patients where even in city like Mumbai where facilities are available, CBNet is not sent. That is one thing. Second, before she came to us, there were 2 episodes. One is of developing meningitis. Second, she developed abdominal complaints. Now, again, when she developed abdominal complaints, she didn't go to a medical college, but went to some local hospital. Again, there she was just given symptomatic treatment for that particular abdominal subacute intestinal obstruction, given some random antibiotics and sent away. Now again, we should have thought there that whether this is the drug resistant TB which we are missing or drug sensitive not responding. So that aspect was not looked into why the patient who was started on drug sensitive 1 month, something like that. And again, symptomatic therapy was given. And by the time she came to us in May, it was almost 6 to 8 months, and she was having a low GCS. So, we have lost a period of around 6 to 7 months in actually knowing what type of TB we are dealing with. So, this was a drug sensitive case. Had it been a drug resistant case, the patient would have succumbed, because drug resistance with so much of dissemination, it is a very bad prognosis in such cases. Even in this patient, now that she is responding, but we don't know, because she has sigmoid sinus thrombosis, she has certain vasculitis like features in her MRI. We don't know what would be the final outcome, because sometimes it happens, late onset paradoxical reactions can come up in these patients and they may develop permanent deficits. So what we want to highlight is, when we have such a patient of presumptive TB, our guidelines are very clear. We have to send a CBNAT and a culture, try to establish a diagnosis. If we are not able to get a positive report, fine, then based upon our clinical and radiological support, we can go ahead and start treatment. But these patients need continuous monitoring. And if any event is happening in the intervening period, we again have to revisit the case and start investigating from, point number one, what is going on, not just give symptomatic treatment and send the patient away. I think those are comments from our side.
Thank you so much, Dr. Sushant. And you've taken up quite good points that universal DST should be done in all the patients who are suspected of having TB, to rule out DSTB, because that will help us in deciding the treatment. Dr. Julika, do we have questions in the chat box?
Yes, Dr. Khushbu wants to know if PID was ruled out in this case.
Dr. Sushant?
Yes. We had sent PID when the patient became a little better. Actually, we had got a low therapeutic levels, but we also sent PID. The reason for sending PID, there were two reasons. One, she was a disseminated TB at multiple sites, and second, she also had a chronic ear discharge, where in our place also she had grown Pseudomonas. So two infections of different organisms. We had sent a PID workup, but the primary immunodeficiency workup was normal. Nothing abnormal was detected in this patient.
Any more questions, Dr.
Yes. There was another question that when should we consider therapeutic drug monitoring in pediatric TB? So, Dr. Sushant, would you like to add some other points?
Yes. So first of all, like we said, when we are having a diagnosis of TB, if it is a microbiologically confirmed TB, whether it is drug sensitive or it is drug resistant, the patient, we have to ensure that the patient is taking the medications properly, the compliance and adherence is good as advised by the doctor. And like we discussed in the upcoming slide, the patient is tolerating the drugs, not having repeated episodes of vomiting, not having malabsorption, all these things are ruled out. And still the patient is not responding to our therapy at the end of 4 weeks. That is, no clinical response, no radiological response, or maybe worsening clinically and radiologically. That is the time we think that this could be because of a subtherapeutic level of TB drugs. But again, as we said, we have to rule out all these confounding factors first: compliance, adherence, persistent diarrhea, malabsorption syndrome. Sometimes now we don't see HIV patients in kids so often, but if the patient is having TB HIV co-infection, then whether it is due to a drug-drug interaction, because they are known to reduce the levels of anti-TB drugs, the anti-HIV drugs. So all this is ruled out, and still the patient is not responding. At that time, we would suspect that maybe we are having a low therapeutic levels, and then we send the levels.
Thank you, Dr. Sushant. Dr. Bhardwaj, sir.
Yes, madam. Thank you. I have a question to Dr. Sushant Mane. Dr. Sushant.
Yes, sir.
So,
good afternoon, sir.
I logged in late, but how much the low level of rifampicin and iron the patient?
Yes. So the normal range for rifampicin given was 8 to 24 milligrams per liter, and our patient, the levels were less than 0.2. And in isoniazid, the normal range given was 3 to 6 milligram per liter, and in our patient, it was less than 0.5.
Thank you.
Yes, sir.
Do we have any more questions from the audience? Yes.
Did we have any reasons ascribed to why the levels were low, Dr. Mane? I may have missed it, but was there any?
No, so we didn't find any reason. The clinical pharmacologist suggested that so the 6 hour levels were normal. I mean, there was no extended low levels at 6 hours. So we were thinking of doing a genetic test to see whether it is a fast metabolism or something like that. But the patient sadly was not affording because the genetic test was costing around 25 to 30,000. So we could not go ahead with that step.
No, I didn't mean to ask about the genetic test because that anyway we were not expecting. I was wondering if it had to do with their BMI or compliance, of course, you have covered, or food intake, anything like that, if you found a common factor.
So in history, at least we didn't get that. So compliance was okay. We even asked whether she's taking the drugs on empty stomach. She said yes, she's taking on empty stomach, which was advised to her. So actually, we could not pinpoint what is the reason of that low levels. And even she didn't have any features of persistent diarrhea. In fact, we even when she didn't have symptoms, we did a stool assay to look for reducing substances and fat globules in stools. Even that was negative, stool elastase, because sometimes the symptoms may not be persistent; it could be intermittent. But everything was negative.
Right. Dr. Puri, sir, you raised your hands. So you're muted. Please unmute yourself.
Okay, good afternoon. There is a question of the low level in this case, reason being that the presenter has told us the level were less.
So your voice is not audible.
The presenter has told us that the blood level was less when the patient was on FDC. And when they switch over to the
so we are not able to hear you. Can you either come close to the system or?
The level of the drugs were less. Can you hear me, Dr. Saroj?
Your volume is very, very low.
So the level was less when the FDC were used, the level was less. But when they switch over to the individual drug, the level has increased. So it is a well-known fact that when you use rifampicin and INH in the FDC, there is a 30% decrease in the level of the rifampicin. That we should also keep in our mind.
Dr. Puri, I'd like to address you over here regarding the FDC part and taking the drugs alone. Because we are all aware that INH and parazinamide, they require an acidic medium, so they are absorbed close to the duodenum in the upper part of the intestine, that is jejunum, while rifampicin, because it requires an alkaline medium, it goes up to the terminal ileum. So that is the reason we strongly advise that the FDCs which are available through the NTP, because they have differential dispersion. So that is very important. Then I totally agree that the formulations which are available commercially, they do not take this into account. And rifampicin and INH and parazinamide, in fact, they hinder each other, because of the medium in which the absorption is required to occur. So that is one of the reasons that the Global Drug Facility, when it came out with the FDC, it had highlighted this point that the two things which are taken care in the FDC for optimal absorption. Number one is the ratio of the drug, because this is the only combination which has got 1:1.5 is to 1 is to 3 of rifampicin, INH, and parazinamide. And also the differential, as I've said, that the differential dispersion in the gut. So otherwise, if you just take the locally commercial drugs in the FDC forms, it's quite true that they may hinder. The other thing I would like to add over here is, we should, I have lost, in fact, 3 cases in my career where, in fact, one I distinctly remember That was the child. I'm talking of those times when the total drug monitoring facilities they were not available. I mean, in north of India, we had to send samples to NIRT Chennai, and that also very selected patients. So this was one child, and this example I frequently even quote in the presentations. You know that this was a mother-child pair who mother was a school teacher, she was the DOTS provider, and the mother was so sure that she gives the drugs to the child. And all the results from our lab, they always showed that the drug sensitive organism sensitive to all the drugs. And I used to ask her repeatedly that, are you sure that you give the drug? वो कहती डॉक्टर साहब मैं स्कूल जाने से पहले इसके हाथ में इसको सामने देती हूँ. So सामने देना और सामने मुंह में डालना, there is a difference because unluckily we lost the child, and the mother, she comes to me after 1 month, and she got the pillow. The pillow of the child was stuffed with all the medicines. तो माँ और बच्चा दोनों स्कूल में जाते थे. मॉर्निंग में टाइम इज सो प्रेशियस बिकॉज एवरीबडी इज टाइट ऑन टाइम. So she would hand over the drug to the child, and the child would, obviously, for the reasons, he would not eat those drugs and put them there. So I would say that always look for simple things. As Sushanta said, that we are talking of microbiologically confirmed, then there is no problem. So clinically diagnosed, obviously, so the first thing is that we have to review the diagnosis, that whether it is tuberculosis number one, whether it is TB or not, and then whether there are any other comorbid conditions like what we have discussed, diabetes, HIV. Even diabetes is known to cause low drug levels. There have been plenty of studies which have been carried out. Then also non-response could be due to some superadded infection, because over here in this case, what I have seen, the overall, one Sushant I would like to share is that, in Mumbai, they are very fast to do higher investigations. जैसे CT, MRI, मतलब वो CT abdomen करवा लिया, ultrasound और X-ray abdomen नहीं हुआ, then you are suspecting subacute or acute intestinal obstruction. Standing X-ray, plain X-ray abdomen is a very simple and easy investigation which tells you which side are you going. Or even examination of the abdomen, presence of bowel sounds, exaggeration, absent or not, could be paralytic EDS accompanied. Then even in the initial episode, ENT examination, a proper ENT examination, because initially what I feel is that later on, obviously, over the course, tuberculosis, MPB was detected by CBNAT. But initially, it could have started as an episode of chronic mastocytitis, where Pseudomonas is a non-causative organism. So, and the local complications like subdural or epidural abscess or localized meningitis could have been due to Pseudomonas. And regarding calling it disseminated, I would say still, one should always get a repeat ultrasound or CT done if required, but not at the first step of abdomen. Because I'm not convinced that it's abdominal cause. It could be because of the associated chronic appendicitis, that there is some degree of intestinal obstruction because they're subcentimetric lymph nodes. So repeating the test like ultrasound to just tell us about the size of lymph nodes, because then even whether the lymph nodes they are mesenteric or the site of lymph nodes accompanied with ascites, yes or no. Because the message which I want to give to the house is that such CT findings should not immediately prompt a person to start ATT. Your case, because you were able to fish out the on CDMAT. The other thing I would say is that once you please, somebody is unmuted, please mute. So the other thing I say is that whenever you are examining a child where the diagnosis is at stake, please examine the child as a whole. ठीक है, अगर और चेस्ट एक्सरे स्पूटम या जो भी अप्रोप्रिएट रेस्पिरेटरी स्पेसिमेन है वो जरूर करवाइए. इवन सर्वाइकल लिम्फ नोड्स करवाइए. वी हैव पिक्ड अप cases where the cervical lymph node there was intestinal tuberculosis and the diagnosis was made based on the cervical lymph adenopathy. Now, these are some of the points which I would like to say. And the other thing I would like to say is, to give the choice of antibiotics. Antibiotics over here, they were started meropenem, amikacin, and linezolid. One should always remember that these are the drugs which are, the reserve drugs which we, until and unless the sensitivity shows that the organism is sensitive to these drugs. Just to start a case who has got, chronic abdominal findings, just to give meropenem, a course of meropenem, linezolid, and amikacin should have been avoided. And we have discussed about the right dosages and the compliance. And then also, not related to this case, but if there is a poor response, especially in children, one should always remember the TB iris. And finally, obviously, it would be MDR. And now coming to your case, because there have been documented subtherapeutic levels. So what you did was the most appropriate, which should have been done. So I totally agree over there. But for me, the diagnosis still does not. I'm not convinced that it is abdominal TB along with. Yes, these are the things which I just wanted to add. I think I
Thank you, ma'am.
because I just thought I might forget.
Yeah.
Thank you so
ma'am.
much,
There is
your
one-
writing. Yes,
Yeah.
Dr. Sushant.
There is one question. I don't know. I have no reference. Somebody has put, are there any fixed guidelines or protocols? How much dose to increase? At least I have not come across such fixed protocols.
So,
We do it on a case-to-case basis.
It's on a case-to-case basis. Yes.
So as per there's no guidelines on TDMs and when to do and how frequently we need to repeat and how to go about in managing this patient. So maybe in future we will come up with some guidelines with our experiences, shared experiences. So as of now, there is no such protocol in place.
Yes. Thank you, ma'am.
And the worst scenario is that even after increasing the dosages, if your patient does not improve.
Yes.
Okay. So there are injectable formulations which are available. That is rifampicin, INH, pyrazinamide. They are there, but they are not available with us. With us, we have rifampicin available in the injectable form. INH. One company from Nagpur manufactures it. They always are seen whenever I've had the chance to check. It's always not available. So, in such rarest of rare circumstances, sometimes we have to shift over to the reserve drugs. If the patient, like in your case, luckily a patient, you were able to achieve the therapeutic range, and more importantly, a patient is improving. There is clinical improvement, radiological, I think, also radiological, Sushant.
Yes, ma'am.
है ना, तो तुम्हारी तो सारी इम्प्रूवमेंट आ रही है. So for you, you are okay. But for those where there is no improvement even after reaching up to the dosages beyond which it would be outside the therapeutic range, that is the toxicity it appears. In those cases, sometimes we have to shift to the reserve drugs.
Yes.
Bedaquiline-based regimen. That is just, you wanted to add something?
Can I come in, Dr.?
Yes, sure.
So, Dr. Sangeeta has just published recently a very nice paper. Dr. Sangeeta, you could summarize that paper here. And I'll just finish in just 2-3 sentences. We have published a series of papers, one in pulmonary TB, where in retreatment patients, the erstwhile category 2, we showed low levels. We then published an abdominal TB. This was published in 2023 in IGTLD. this year there is a paper in TB meningitis. So the lower drug levels remains a problem, and we need to find a concrete solution. But like Dr. Sangeeta said, in the therapeutic range, we can increase the drug dosages. So there was a question in the chat box which says when to recheck the drug levels. So the drug levels take about a week, 10 days to stabilize. And drugs like, so different drugs have different pharmacokinetic profiles. And some drugs tend to bind to protein, some drugs tend to bind to fat in the body. So the drug stabilizes, and then you can assess the drug levels maybe 2 to 3 weeks after increasing the dosages. So that was the reason I wanted to come in. And Dr. Sangeeta, please summarize your paper. Our papers were around lower drug levels, especially in extrapulmonary TB and in TB meningitis, because of the blood-brain barrier, the blood CSF barrier. The drugs do not really reach the levels that they should be reaching in the CSF. So our paper was about that, which is under communication right now. Again, in abdominal TB, our levels have to be higher. So what we were proposing was to look at alternative regimen, especially for extrapulmonary TB and, things like TB meningitis and so on. So,
So thank you, Dr. Urvashi. I mean, that's really very, very important. You know, that in extrapulmonary tuberculosis, when you have GIT tuberculosis, or even in PBM, you know, I mean, because of syndrome of inappropriate secretion of ADH, it causes metabolic disturbances, and that's a reason for, low bioavailability, that is absorption of drugs. One should always remember protein losing enteropathies and protein losing nephropathies as causes of low albumin levels, because they can also be cause of low therapeutic levels. So, regarding your question, and regarding the two papers which they are already in public domain, one study was done by NIRT, Chennai, in which we assessed the first line drugs as well as the second line drugs. So it was found that the levels of first line drugs, especially rifampicin, they were in the subtherapeutic range in a significant higher number of children, and the best first line drug which attains good blood levels was pyrazinamide. So the second paper, which was a part of the benefit TB trial, that is from the South Africa, in which they linked the blood levels, the PK levels, with the anemia for linezolid. This was particularly for linezolid. So linezolid reaches therapeutic levels, and they did not find any significant difference between HIV seropositive as well as seronegative. And so anemia in linezolid is not related to the therapeutic levels, but it is due to the pre-treatment hemoglobin levels. So it was decided that this paper, it led to the conclusion that, you know, the initial at the start of treatment, the hemoglobin, if you are able to get it to a level of 10 gram percent and above, so chances of the child landing to anemia because of linezolid drastically they decrease. Leaving aside, irrespective of the cause, because being a chronic disease, hemoglobin can be, or worm infestation, any cause. So we have to cause. Please, can you mute your? So treat the cause of anemia, and be it any anemia, be it iron deficiency, be it dimorphic anemia, or vitamin B12 folic acid anemia. The cause of anemia has to be treated, and in the circumstances where the time is short, even a blood transfusion to get the levels above 10. Which this practice we are routinely following in our center of excellence. We do not start the MDR-TB treatment. provided the hemoglobin is 10. We try to give blood transfusion, etc. So these are the two studies, Dr. Rishi, which they have recently come in the public domain.
Dr. Alup,
you wanted to add something?
Hello, Dr. Sudham, very nice case presentation by your team. I just add something regarding the pediatric tuberculosis. Actually, in the pediatric tuberculosis, there is weight band wise, there is drug doses. As Madam has already mentioned that the doses, perfect doses are very important in these children. As the initially weight of the child is 29 kg, in that situation and later on when the child is readmitted at your side, the weight is 25 4 kg. So in the both time you started the drug level of 3p plus 1a plus 3 that is recommended. But I just want to add one more thing that weight should also be taken on the regular routine checkup when the child has come and if the child weight band had changed from 29 level to 30 level and 40 to 41 level or 16 to 24, 24 to 30 level. So whenever the weight has changed, you have to change the regimen also. So in these children, I especially feel that initially the weight was 29 kg, the regimen was started 3p plus 3a. So in the routine checkup, the weight to the weight also, so that we can change the doses in that particular weight band. I just want to add this one thing. And another thing, as ma'am had already told that CT thorax and the CT brand venogram, all these things have done in the initially in this test, but the sputum, the basic sputum CVNet was not done at that time. So if we find out the sputum CVNet at that time and do the culture, we can identify these children earlier rather than delaying in this regimen. Repeat, start the case. Thanks.
Thank you, Dr. Alok, for highlighting very important points in the management of TB pediatric cases. So, do we have any other questions from the audience, or shall we move ahead?
Ma'am, I have one question.
Yes, Dr. Ankur.
Ma'am, there is a particular kind of formulation available in the market in ATT, which is in a powdered form. So the taste of that formulation is a little bit bitter, and sometimes patient is more comfortable to take that powdered formulation, mix it mix it in a cup of water with some sweeteners or sharbat, so that they can easily take the medicine. So my question is whether this powdered formulation can have an impact on the therapeutic blood levels, and if yes, then can it be taken with some sweet so that the bitterness goes away and the patient can take the medicine? It is more relevant in case of pediatric population because the tablets usually have they are difficult to absorb, kind of thing. Thank you.
Dr. Ankur, do I answer this question?
Yes, please.
So, Dr. Ankur, I would like to say that, the drugs, the three FDC, that is freely available under NTP. So, the formulation, as I discussed in detail, the formulation that is dispersible. It has got three drugs, that is rifampicin, INH, and pyrazinamide. As I also discussed, that the ratio is also ideal. All the drugs, they have been combined in a ratio because when we were, the ministry was trying to procure the drugs. There was no medical company which was there using this ratio of the drugs. So that was one of the reasons it took a while for the ministry to acquire these drugs. I'm talking of way back early 2000, 2010, because these FDCs came later on. Two, three times we had to do the tender and only single times then we called the companies and none agreed to take it. But then the ministry took a call and finally these dosages and the drugs they were manufactured with the collaboration with the WHO, the Global Drug Facility, etc. So so for rather than powder, why don't you go ahead and prescribe your patients with dispersible tablets which are freely available under the program? Why do you want the powder? I mean, you have to answer my question. Why do you want
Ma'am, one of a patient came to me with this particular formulation. It is not available at our place, and patient
And you
came to
should
us.
you should counsel your patient that look
Yes, sir.
here, you don't even need a powder. These
Yes,
are
sir.
dispersible. You just put one drop of water and it becomes like a liquid.
Okay, ma'am. Thank
You
you,
know,
ma'am. Thank you.
Thank you. The post-test link has been shared in your registered email ID and in the chat box also. Please attend before leaving the clinic. So, with this, let me summarize the major points which we have learned from today's clinic. Universal GST should be followed by each one of us when we are dealing with the TB patients. I agree that getting a sample done from extrapulmonary TB is little difficult, but we should try all the methods to get a sample. Rifampicin and IH interaction should be considered while going for a low drug doses levels. We should keep in mind, but should not be taken into. Compliance should be checked in each and every patient before we suspect low therapeutic levels in the patients. As such, judicious use of TDM facility as of today is advisable because everybody should not under the patient should not be advised TDM for any cause. We should judiciously use it and should focus after ruling out all the possible causes of low therapeutic level.
this is very, very important. आफ्टर दिस ये नहीं होना चाहिए कि हर किसी का टीडीएम कराना शुरू कर दो. दिस इज वेरी इंपॉर्टेंट. यू हैव टू रूल आउट ऑल द अदर कॉजेज of, as we discussed, that the causes of poor response could be based on diagnosis, drugs, then drug dosages, then the formulation, then you can check the expiry of the drug, then also the compliance. For that, I would strongly advise that those patients who are not improving, for them, the parents or the treatment provider should be instructed to go back to the original strategy of direct observation. Because I discussed that patient with you. So, although children are very smart, they can never say कि वो नहीं खा रहा दवाई. So, but directly observed it should be the first thing which needs to be done.
Yeah. And these patients are chronic patients, so they are most of them are malnourished. So nutritional supplementation and should also be considered when, like ma'am has beautifully indicated, low protein levels. It can also be the reason for low therapeutic doses in the patient. So all these things should be ruled out. And yes, we should not over investigate our patients. So with this, I would like to call Dr. Ashok Bhardwaj sir, who is chairperson of the National Task Force, to deliver his closing remarks. Sir, over to you.
जस्ट सर मैं जस्ट एक चीज ऐड करना चाहूंगी. मतलब जो इस केस से जो लेसन है विच वी ऑल नीड टू रिमेम्बर इज दैट वी नीड टू हैव अ कंप्लीट एग्जामिनेशन ऑफ द चाइल्ड. ठीक है, मतलब स्टार्टिंग विद सिंपल कंप्लीट एग्जामिनेशन एज आई स्ट्रेस्ड कि चेस्ट एक्सरे कराओ, स्पुटम करवाओ, सर्वाइकल लिम्फोडेमापैथी देखो. मतलब जो इस केस से हमें समझ आया, they went ahead with CTs, MRIs, CT abdomen, X-rays हुए नहीं. So I mean ये practice, because we are exposing the child to unnecessary radiation also, and obviously these they are quite expensive also. So that is the only thing which I want to.
Sangeeta, if I may, I was just thinking, you see it's an inhaled pathogen. We are inhaling from the air. So when the child even presented with the ear lesions, the initial infection must. So I think what you are saying is, as it is very, very important. We have to catch the disease early. We must rule out pulmonary involvement. Of course, we do not have 100% NAT sensitivity in children with pulmonary this thing as well. But it must have obviously moved from pulmonary to the extrapulmonary side, which are more difficult to diagnose and more difficult to treat. The drug levels do not reach there, and also diagnostic techniques may not be as successful as in a pulmonary, though pediatric diagnosis is much less sensitive, like I said, even using that. So what is very important is early suspicion, early diagnosis. So I think that is a very important message that should go across. Why wait till the child progresses to, of course, there is a flaw at the end of the patients who come in late to the system, and also, so at least the medical fraternity can work hard to diagnose early. Thank you.
Thank you, ma'am. Dr. Bhardwaj, sir, please go ahead.
Thank you, sir. First of all, I must congratulate Dr. Shashant Mane and his team for wonderfully presenting this case. So I joined late, but it was wonderful information, and the views expressed by and discussion by Dr. Sangeeta Madam was excellent. So I would also like to convey here that the information given by Madam Urvshi, it was also quite informative. So here because therapeutic drug monitoring is important, but it should be the last resort. So it should be used selectively. So here I also want, because the facility is not available everywhere in the country. So here I also want to take this platform to request DDG Madam that we should explore possibility of providing the at places where the case load is very, very high. So thank you, NIRTRD for giving me a chance. It was a wonderful case. So I got information late. Otherwise, when I could have communicated to many people. So thank you very much.
Thank you so much. It's always very optimistic of you, and it's always good to have you, sir, in these clinics. And with this, we end today's session. And much congratulations to Dr. Sushant's team. And I would like to say special thanks to Eco India team and Mrs. Shifa Khan, who is behind the scene, but she's doing a lot of hard work in arranging these clinics and to run smoothly. So thank you, Shifa. And thank you, everybody. With this, we are ending the session.
Sir, we are holding these clinics every month, sir. So it's second Tuesday of every month, 2 to 3 p.m.
Third Tuesday.
Third Tuesday. Third Tuesday, 2 to 3 p.m. So it's a monthly event, and we are getting support from all our pediatrician colleagues, national experts, the state experts, and all the difficult to treat children. I feel that children and adults management of tuberculosis is nearly the same, except for a few subtle differences which we tend to discuss. Otherwise, I would strongly advise everybody to join in, be it chest specialist, adult specialist, or a pediatrician. Thank you so much.
So our next upcoming session will be on 19th of November. The team will be from AIMS Bhubaneswar. So requesting each one of you to join and encourage else to join this session. So thank you so much.
Thank you, ma'am.